Doctors Christine and Thomas Fensky are internists at Medical Associates Clinic and Health Plans in Dubuque, Iowa. They are frequent invited lecturers on practice innovation, redesign, and the patient-centered medical home, and have given workshops for the American College of Physicians, the Institute for Healthcare Improvement, the New York City Department of Public Health, as well as private and academic medical centers. Dr. Christine Fensky served on an expert advisory panel for the CMS Innovation Center's Comprehensive Primary Care Initiative and is a co-author of the Institute of Medicine's 2011 report, Health IT and Patient Safety. In addition, she is a director on the American Board of Internal Medicine. She has also provided testimony to the Office of the National Coordinator for HIT on EHRs with respect to both care coordination and usability. Both Drs. Fensky are investigators for an American Board of Internal Medicine Foundation study of high-functioning primary care practices. Dr. Fensky received their BS and MD degrees from the University of Wisconsin-Madison and completed their postgraduate residency at Gunderson Medical Foundation in La Crosse, Wisconsin. It is my great pleasure to turn today's webinar over to them.
Great. Thank you so much, Paula, and thank you to all of you for joining us today to talk for an hour or less on Streamlined prescription management. And we hope to show you how you can save an hour per day in your practice around prescription work. Our agenda for the next 20 or 25 minutes will be a brief introduction, and then we'll spend most of our time talking about an approach to prescription management, a streamlined approach. And it's one of 8 strategies that Tom and I have pulled out of our own practice, what we call our core team model. And I will briefly, later in the webinar, tell you about the other 7 strategies so you can see how this fits into the core team model, which is our means of developing the efficiency to deliver the patient-centered medical home. And then we'll end with some Q&A. So before we start, though, I'd like you to reflect for a minute on your own practice, either as a provider or how the providers manage prescriptions in your practice. And that is, how are prescriptions written, whether they're on paper or electronic? How is the number dispensed determined and the number of refills determined? Is it intentional or sort of random? And how much time is spent per practice on prescription renewals? And when you're thinking about this, I want you to think about time that's spent in the office visit itself, as well as time that the medical assistant or nurse is spending responding to phone calls or faxes, the amount of time the physician might be spending managing prescription requests on the inbox list. Think about each of those. Well, here's a family physician in Minnesota who said to us once, "Prescriptions are killing us. My nurse is spending so much time on refills that we can't seem to get anything else done." And Tom and I have had the opportunity to shadow about 50 physicians and their staff across the country. And one of the constants that we've observed is that it's not at all uncommon for a group of 6 to 8 physicians to hire one nurse who does nothing but prescription renewal work full-time. That's a lot of nursing work that can be redeployed to higher value medical home activities if we can re-engineer some of that prescription work out of the practice. So the history in our own practice is that many years ago, we did a survey, and at that time, the majority of calls coming into our practice were requests for prescription renewal. So we decided to take a systems approach to that, to try to eliminate having to redo the same work over and over again throughout the year. And what we did was we decided to renew all chronic illness prescriptions for 1 year at the time of the patient's annual comprehensive care visit. And that single change in our practice reduced the number of phone calls into our office by 50%. So I'd like to turn it over to Tom, who's going to tell us more about synchronized bundled renewals.
Thanks, Chris. So the strategy that we have developed and that we use is called synchronized bundled renewals. And in this system, all prescriptions for each patient are renewed and resynchronized at the time of their annual visit, their annual comprehensive care visit, or nowadays the medical annual wellness visit. And what we do is we dispense 90 and we provide 4 refills. And this provides a 15-month window for the patient to schedule their next annual visit and then have this process repeated at that time. Now, the synchronized portion of this system is very important. The patient is on multiple medications. Throughout the year, they may be started on new medications. They may have doses changed on medications they're already on. So when it comes time for their annual visit, they may have various medications that have several refills left. Well, we take all of their prescriptions and we resynchronize them. We start over with all prescriptions and we renew them for the next year. We also send a note to the pharmacy canceling any ongoing refills that remain so that there's no confusion on which prescription they're actually filling. Another important part of our system is that we do not use prescriptions as a hook to bring patients back for monitoring visits throughout the year. Instead, what we use are planned care appointments. If we want to see a patient back in a month or 3 months or 6 months, we set up that appointment when the time at the end of this visit. We also pre-schedule any lab that we want to have the results available for at the time of that visit. And then the patient will receive a reminder phone call and or letter reminding them to come in for that follow-up visit. Now, we do that because we want to separate the work of monitoring from the work of renewing. Because we want to avoid loading all those interval visits throughout the year with the unnecessary, redundant, and really wasteful work of prescription renewal. So a simple example of how this saves time. Let's take an example of a patient who's, let's say, on 6 to 8 chronic medications. Well, before we put our system in place, we may have received 6 phone calls or nowadays 6 faxes from the pharmacy throughout the year as various prescriptions randomly came due for renewal. After we instituted the system, we may well receive 0 phone calls or faxes. Well, if you take that 6 calls or faxes and you multiply it over a patient panel of 1,000 to 2,000 patients on multiple medications, we can see the enormous savings in time and work that the system provides. Something happened to me about 3 years ago that really drove home the power of this particular strategy. My primary nurse, Maggie, came to work for me at that time. Now, she had been working in another practice where they did not follow a synchronized bundled renewal system. They simply randomly were renewing medications throughout the year. After Maggie had been with us for only 2 or 3 weeks, she mentioned to me not once but several times that she noticed that she couldn't believe how little time she was spending on prescription renewals since she'd come to our practice. And after she'd mentioned it a few times, I asked her to try to quantify the difference. And she estimated that it was probably only about 25% as much time as she had been spending in the previous practice where the system was not in place. So because of that story, we decided to check some data. And we did a time study in our own organization. And we took the nurses from 14 primary care practices, and we gave them stopwatches. And we asked them to collect data for 1 week. We asked them to hit that stopwatch whenever they were doing any prescription renewal work during that week. Now, this might include receiving faxes or talking to patients or pharmacies on the phone about prescription renewals, reviewing the chart to be sure that this renewal was, in fact, appropriate, talking with the physician about the appropriateness or the renewal request, returning the faxes, and also documenting the prescription in the electronic health record. Now, we asked them to do that for 1 week for all prescription work except for narcotics and benzodiazepines, because these are medications that we cannot renew for an entire year. And when we collected that data, we found that those practices within our larger clinic that were following a very strict synchronized bundled renewal system were in fact only spending about 20% as much time on prescription renewal as those who were simply following a random prescription renewal method. It's interesting because it correlates very closely with Maggie's estimate. We decided to use that data to make some estimates about the economics of our prescription renewal using the case of our own larger clinic. In our multi-specialty group, we have 27 primary care providers. And we estimated if those providers do not use a synchronized bundled renewal system. If they would not do that, we would lose as much as $100,000 per year in nursing time. In addition, we would lose opportunity costs. We would have opportunity costs because when the nurses and the physician are spending time renewing prescriptions over and over throughout the year, that's less time that they can provide access for patients to be seen. We estimated that, very conservative estimate, only seeing 2 fewer patients per week because of this wasted renewal work, we would have lost $240,000 in physician productivity. So a total of $340,000 estimated that we would lose if we were not using the approved system. There's also the issue of job satisfaction. If nursing staff can be freed up from the tedious and really wasteful work of prescription renewal throughout the year, they can do the higher level of medical home duties that we really need to have done in the medical home, such as health coaching, chronic care management, and so forth. And it provides a much better job satisfaction for the nurses. They can be interacting with patients in a meaningful way rather than doing this tedious work of renewal. It's also good for patients. There's evidence in the literature when patients do not have an organized approach to their prescriptions that there actually is a decrease in medication adherence. And this is rather obvious because if their prescriptions are running out, they're not filling them or for a few weeks or sometimes a few months throughout the year, they're going to be less adherent to their treatment plan. If you'd like to read more about the synchronized bundle renewal system, there is an article that we wrote that was published in Family Practice Management in November and December 2012. So at this time, I'll turn it back over to Chris.
Thanks, Tom. So what I'd like to do now is show you how the prescription approach fits into the larger model of care, which we've called the core team model. Again, our way of achieving efficiency so that we can deliver the medical home. So the first strategy is plan your appointments. And as Tom alluded to, in our practice, we do 95% of the lab ahead of the appointment. We prospectively plan the next appointment at the conclusion of each visit, and we prospectively plan the lab that's associated with that. The reason we do that is that allows the patient and the physician to talk about the results face-to-face at the visit, and the patient can be engaged in shared decision-making around those results. And I think that's a better model of care for patients than if they get their results over the phone and are just told what to do. We use our visit planner, the checklist, as a way to orchestrate those planned care appointments. So the physician checks off the things that are to be done at the conclusion of each visit. The patient takes that up to the receptionist, who schedules the next appointment, say a 3-month appointment with lab a few days before. Empowered teams, that's the physicians and the nurses or the medical assistants working together in a stable relationship, same group of people every day, to empower the nursing staff to take ownership of, in our practice, they take ownership of all the prevention work, and they do a lot of the health coaching and the care coordination. We use a pre-appointment patient questionnaire that the patient completes in our waiting room, or other practices could do this electronically, for agenda setting, so the patient and the physician really know the scope of what's to be covered during that visit. The annual exam or the annual wellness visit for our Medicare patients, that's the organizing principle. That's where that's how we organize all the chronic illness care, all the prevention, and all the prescription work for the patient throughout the year. And then rapid access, that's our same-day access for patients so that they can see their personal physician for problems that develop on a same-day basis and allow that continuity with their regular provider. And then we've tried to build in a lot of intentional behaviors for relationship building and self-management support. So in a nutshell, that's the core team model. And the overall goal is to re-engineer the way we do our work, to reduce the amount of rework, make work, or misdirected work that can otherwise kind of clog up the gears in the machine, if you will. So I'd like to illustrate how this fits together with a case. So this is a 66-year-old male with diabetes, hypertension, hyperlipidemia, and depression. Pretty common scenario for our family physicians and general internists. And he's on 5 medications as listed. So in terms of the synchronized bundle approach to his prescription, he comes in for his physical exam in December. And at the conclusion of the visit, I'll have indicated what changes, and the nurse will send those prescriptions then off to the pharmacy. And she'll send off all 5 prescriptions with 90 days and 4 refills. We'll also set up the patient for a 3-month appointment and for lab ahead. So he'll get a phone call, a text, or a letter reminding him about that lab a couple of days before it's due. And then by the time he comes to see me, we'll have the results. So in this case, his A1C was higher than our target goal for him. And we could talk about that face-to-face at the visit. And we could talk about what some of the options for management were. And in his case, he elected to increase his metformin. So at the conclusion of that appointment, my nurse sends the prescription off to the pharmacy for the newer dose of metformin and alerting the pharmacy to cancel out that earlier prescription for metformin. And at the same time, we arranged for him to come back in 3 months to check, and he'll have had lab ahead for that appointment. And then if need be, he'll come back in September. And then when I see him in December, we'll renew all of his prescriptions again. We'll start afresh. We'll resynchronize all of them so they all now have 90 days plus 4 refills. And over the course of the year, for that one patient then, we've had to process prescriptions for him 6 times, 6 prescriptions that have had to be managed. And I'd like to contrast that to another approach, and that is the approach where the prescriptions are used as the hook or as the enforcer to bring the patient in for the next appointment. The rationale here is give the patient 90 days so that they run out and have to come in for their next appointment. And so in that model, when the patient does return in 3 months, the prescriptions are all reprocessed and re-renewed. And then when the patient comes back in June, they're re-renewed, and when they come in September, they're re-renewed again. So over the course of the year, in this model, the prescriptions had to be processed 20 times through the year. Quite a bit more. But it's actually even a little bit more complicated than that, because what often happens in my experience is that the patient runs out of his prescriptions after 90 days or so, and so he calls in, but he doesn't have an appointment, so he calls in the clinic and he has to get another bridging prescription to last him until the next appointment, which he also schedules that day. Another thing that I've seen fairly commonly is that patients are asked routinely at their appointments, do you need any prescriptions renewed? And the patient will say, I don't think so, no. And I certainly wouldn't know about it myself. And then what sometimes happens is a week after they've been in for their appointment, here comes a call or a fax with a request for a prescription renewal. Maybe the metformin has run out. And I've sat next to nurses doing prescription triage, and they'll be handling another prescription for a patient. They'll say, well, this patient just called in a week ago for their metformin, and now they're calling in for their atorvastatin. So there can be a lot of unnecessary turbulence in the process with all of this rework happening. And then a third approach that I think people can take, and I honestly took when I first was in practice many years ago, and that is just kind of random. I pull it out of the air. Oh, I guess I'll give them, 60 days, and I'll give them 3 refills. And so in this way, the prescriptions are completely decoupled from the in-visit care. And that, too, can end up with lots of prescription touches throughout the year. So that's quite a bit for one practice, but if we multiply one patient, but if we multiply that across the practice, I think in many family practice and general internal medicine practice, this is maybe 1,000 patients who have some chronic illness with an average of about 3 prescriptions per patient. And they may have to call on 3 or 4 times a year. Well, multiply that across the whole practice, and that can be as many as 10,000 or more phone calls or faxes to be managed. And each one of those, I think, reasonably could be expected to take 1 to 2 minutes to accommodate. And across a whole year, that's 300 hours of nursing and, in some cases, physician time per year applied to this work, that most of which could be re-engineered out of the practice. So in another way that we've looked at this is we've shadowed physicians and their staff in practice. We've come away recognizing that most physicians can save 30 minutes of their own time that they currently spend on prescription renewals, whether it's in the office, at the follow-up visits, or more commonly at the task list level. And that nursing time, about an hour of nursing time per physician per day can be saved. You may say, well, what big deal? 30 minutes is sufficient time, an hour of nursing time. What does that matter? But if we multiply that across all the primary care physicians in the country, and then we estimate that by saving that some of that time, each of those practices could see one more visit a day, then that's a capacity for 80 million more primary care visits per year that's not yet recognized within our primary care system. And in my view, that's a lot of waste in our system, and a lot of waste that we can ill afford at a time when we actually need more primary care physicians rather than less. So before we turn it over to questions, I wanted to close with this quote from Sir William Osler, who more than 100 years ago, I think, really hit the nail on the head for the situation in which we find ourselves in today, when he wrote, "Medical care must be provided with utmost efficiency. To do less is a disservice to those we treat, and an injustice to those we might have treated." So at that, I'd like to open it up for discussion and also highlight for you that I did put some references at the end of this webinar on prescription management and on the core team model. And if you're interested, you could look at those references. And so now, Paula, I'll turn it back to you and be happy to answer questions, as would Tom.
Very good. For folks who are on a computer system rather than through the teleconference per se, if you want to text a question, you may do so over in the chat box on the right-hand side of your monitor, or I will just, at this point, I will open the lines back up, and please do keep your phone muted, though, if you are not asking a question. And you should all now be unmuted. And go ahead with your questions for either of the doctors. Thank you.
So we try to look up that would be helpful. Improvement at, that last one.
So that's from the family practice?
Yeah, the improving office practice. We're working harder, not smarter. Okay. Yeah, we're muted. Yes. Did you not hear it? Okay.
I'm sorry. Is that a question? I missed it, I guess.
I don't think we'd be able to implement.
Chris, I have a question.
Sure.
Go ahead.
Go for it. No, go for it.
When you started this method in your practice, how did you go about beginning it? Did you start with one of the clinicians, or did you just decide, we're just going to go for broke and just do it across the practice? How did you go about it?
Well, excellent question. The way we went about it was in one practice. We realized that we were probably wasting a lot of time responding to all the requests for prescription renewal, and we decided to start renewing all the prescriptions at an annual exam. But now we realized that was going to take us a year before we'd reach the full benefits. But within a 3-month period of time, we had already started to see a decrease in the number of phone calls coming into the practice. And my suggestion for any practice that wants to do this is to start with the patients who are there for their annual appointment. And for those patients, develop a workflow wherein you can consistently renew all the prescriptions for the maximum amount allowable in your state. And that varies state by state, and we actually have a reference for what the maximum allowable per state is in the Family Practice Management article on prescription renewal.
Great, and this is a related question, I think. I was busy reading it, and unfortunately, I didn't catch. And the person asked, what happens with patients whose insurance covers only 30-day supply of medication refill? How does the synchronized bundled renewal process work in this case?
Tom, do you want to take that?
Well,
I think you. Oh, go ahead, Sarah.
the 30-day, whether it's 30-day or 90-day, the system still works. If the insurance company is requiring every 30 days you provide a completely new prescription without any refills, that is not what I've seen. But the 90 days is just more of a convenience for the patient, so they don't have to be going into the pharmacies so much. So if they only take 30 days, that's fine. We just provide with instead of 4 refills, it's 12 or 13 refills, and that gets them through the year. So you just adjust that part of it. So the 90-day part of it can be adjusted for what if the insurance companies are going to put that limit on the number of fills that they'll dispense at one refill. Now you have to understand the difference between refill and renewal. Renewal is when you set up the prescription and you provide multiple refills throughout the year. A refill is just that one particular month or 3-month period. So the system works in either way. For us, we try to make it as convenient as possible for the patient, so they're not running into the pharmacy every 30 days.
And one of the things we found is that if you can only dispense 30, many states will allow 30 days and 11 refills. So you are confined to be quite organized about when you have your next physical, because that limits you to 365 days in a year. However, for most patients, still, it's much less work than renewing them multiple times through the year.
Another question for either one of you. When you changed to this system, did you have any pushback from your staff? And if so, how did you handle that?
Well, that's a really great question, because I think one of the sort of under-recognized challenges in primary care is the way we leverage the nursing staff. And many practices that we visited said how difficult they found it to keep nurses in the prescription renewal role. So oftentimes that was called a triage nurse, but basically 95% of her day was spent handling requests for prescription renewal. And for many, that's not a highly rewarding position. So I think that nurses can be your best allies in this, because it frees them up from doing a lot of this sort of rote work. And so we found our nurses to be really on board with us from the beginning, because they were the ones who were really bearing the brunt of excess calls through the year. And so I think helping them understand that and helping frame it for nursing staff as a way to reduce their workload around prescriptions is a really appropriate way to frame that.
Thank you. These have been good questions. Any others that you can either ask on the telephone or write them down in the chat?
Well, Paula, while we might be giving people a chance to think about any additional questions, there's one other thing that I'd like to really highlight, and that is that one of the things Tom mentioned, and that is medication adherence, I think, is facilitated by taking this approach to prescriptions, because patients aren't running out of their prescriptions multiple times a year, not having to then call in, because often, I know for myself, that will lead to a 2 to 4 week gap in taking the medication. And we've been doing this for quite a long time, and I just a month or two ago came upon a study where a different term was used rather than synchronized bundle renewals, but when you consolidated is a term that was used in the study. When you consolidated the prescription renewals, adherence was better. So confirming, I think, what our impression had been.
I'd mention one other thing, too, just in terms of getting the system going. There often has to be some communication with the pharmacy, because pharmacies, we mentioned the importance of resynchronizing prescriptions at the annual visit. So, as I said, a patient may have been started on a medication 6 months ago, given a year's worth of prescriptions. So when they come in, they still have this many refills left on that, but we don't want that prescription still in the system because that's going to run out in 6 months and it destroys all the efficiency we're trying to achieve. But what happened initially until we communicated with our pharmacies often is that they would get the new prescription at the time of the annual exam. They'd say, oh, well, we still have refills, and they would throw out. They wouldn't use the new one that we had resynchronized. So we have since communicated with them to understand, and there's also a message from our nurses on the fact that you delete the previous, prescription number and you resume this way, because if you don't have the pharmacies coordinated with how you're doing it, sometimes they'll ignore the resynchronization process and you haven't gained anything. So some communication at times has to be made with the pharmacies that you work with.
And Tom, you've also learned one thing that Tom has learned, because he's been the one who's done a lot of the communication with our pharmacies, is that they really want this to work also, because it's a lot of work for them to be the intermediary on these prescription renewal requests. So it's in their best interest to also kind of work in conjunction with the clinical practice to decrease the unnecessary work that's going around and around prescriptions.